territory is maybe slightly hypokinetic, but not much, especially septal contraction is rather normal. So this patient had initial CK, even blood taken before start of the angiography, very high. So the myocardial infarction already was ongoing for some hours. This meant that the akinesia in the inferior and lateral part of the heart did not resolve. We had a scar there some days later, but the global function improved slightly, and we were content. So we have to discuss, should we have done the LAD procedure in the same session, or should we have done this separately? And we have our guidelines of 2017 for the myocardial infarction treatment. And they say non-infarct related artery PCI should be considered, we should do in patients with cardiogenic shock. This was not a very frank cardiogenic shock, but the patient was not well doing hemodynamically. And the prognostic relevance of the LAD lesion is quite clear. So we decided to do that as recommended in these guidelines. But 1 year later, we have new guidelines on myocardial infarction. And in the meantime, the culprit shock study had been published. And in this study, has been shown that immediate doing of non-infarct related artery leads to a higher 30-day mortality than if you defer it. So, and it leads to more frequent renal function deterioration. So in the next guideline, only 1 year later, they say it's not recommended to do that. So it's a really difficult decision. If you have the acute case, what will you do? Will you stop and go for a second procedure some days later, or will you do it? And my personal view of this is, in the actual case, we did right, because we could do that. We had the wire in, and we could expect to have it done with little contrast, additional contrast media need, and with little risk of compromise in the LAD territory. If we had risk to damage the LAD, or if we had a bifurcation, or if we had large thrombus or much atherosclerosis, much calcification, if it would have been a very complicated procedure, maybe we would have better decided not to do it in the same procedure, but later, for safety reason for the patient. So this is an aspect we can discuss later. What would our colleagues have done in a case like this? I move on to the next case. We have a 76-year-old man who has chest pain on low-level exertion since 1 or 2 weeks. And when he comes to the hospital, he has atrial fibrillation, but not hemodynamically critical. It's a normal heart rate. And he has ST segment depression anteriorly, no ST segment elevation. So it's not STEMI. We have a little bit of time. So we made echocardiography, we found normal function and no valvular disease, which was important also because we had at auscultation found a systolic murmur. But as he had this ST segment depression and elevated troponin and known coronary disease and vascular dystrophy and peripheral arterial disease, we decided to do the procedure on the same day, 1 or 2 hours after hospital admission. And this is what we found. We found normal left ventricular function. We have a lot of calcification in the mitral annulus. We have also calcification in the aortic root and proximal left coronary artery, and nearly all the way down the right coronary artery. So we expect to find rather severe coronary disease, and we start with the right coronary artery, and surprisingly we find calcification but no high-grade stenosis. So we do the left coronary artery, and now we can go home. We have no stenosis. Do you agree? Yeah, little surprise, we have to do more projections. It's always crucial to get projections to have every bifurcation and every part of the artery really free sight on. And the next projection shows the problem. We have high-grade proximal ostial circumflex deletion. And if we go on to analyze this, we see we have atherosclerosis in the left main and also in the proximal LID, but not high grade, and this ostial circumflex stenosis. So if we go on now for the treatment of this, we have to be aware that it can come to a left main bifurcation intervention with maybe 2 wires and 2 stents and kissing and everything. So we prepare for that. This means we use a bigger guiding catheter. In this case, we use 7 French normally, and we wire both vessels, of course. And but we decided, as you can see, it's quite a rectangular origin of the circumflex here, that we would try to do this in a 1-stent procedure in a T-stent technique. So this is what we did. We have the wire in, which was surprisingly easy for the circumflex, but it looked difficult to get in here, but it was not really difficult. So we have 2 wires now, and then we predilate the circumflex ostial lesion, and we have a little less stenosis and no damage to left main and LAD, which is very important. So we can continue with our strategy of 1-stent T-stenting. And what we decided to do here is to put a balloon in the left main to LAD and the stent here in order to preserve the bifurcation and not to damage the bifurcation and not to cause a plaque shift in the direction of LAD during the inflation. And you can see we place it we can place it in both planes quite exactly. And then we do a kissing inflation of both the stent and the balloon. And after that, we have a good result and no damage to LAD and to left main. And we checked this in different projections, and we are quite happy with the result. We can stop the procedure here, and we were lucky that we don't have to do a complex left main bifurcation intervention in this case. My last case is a 60-year-old man coming to the hospital in the morning. He had severe chest pain on that day, but he had chest pain since a long time already. He's a former smoker, but long ago. And he has a peripheral arterial disease, and he's obese. He's rather young. So he comes to the hospital at not early, 8:30 in the morning, and he called the ambulance to come here, and this is the ambulance ECG, which was sent to our hospital. And what we can see is deep ST-segment depression in nearly all extremity leads, and ST-segment elevation in VR. So this is not 12 lead, but when he was in the hospital, we have 12 lead. It's a little bit better now, not so deep ST-segment depression, but the same picture. We have isolated ST-segment elevation in VR and ST-segment depression predominantly in the lateral area. So what does it mean? Is it STEMI? It's not STEMI, of course, because definition requires 2 adjacent leads with ST-segment elevation, but for only 1 lead. But we have to keep in mind that ST-segment elevation in lead VR can be very critical, can be signaling that we have ischemia in nearly all of the left ventricle, which is frequently associated with left main disease. So if we have isolated ST-segment elevation in VR and ST-segment elevation nearly everywhere else, we should be very alarmed. And this is what gave us the decision to go to the cath lab rapidly. And also this patient was not very fine hemodynamically. Also clinically, he was sweating, he had vegetative symptoms, he was not fine. And China also, so we started to do the diagnostics, and we found a stenosis in the right coronary artery, but we have to look closely. What we see is a lot of collaterals to the left system, and you see the calcification near the ostium of the left. And in the other plane, we can confirm this with the right coronary artery high-grade stenosis, and we see collaterals, and we see a lot of calcification at the left main ostial area. So we do the injection of the left coronary artery, and we are prepared to find some serious thing, and we are surprised it's more serious even as we thought, with a subtotal lesion in the left main. And during this injection, it took only maybe 20 seconds to have the catheter here and do the injection. The patient went rapidly worse. The blood pressure got down, and he was threatening to go into cardiogenic shock. And as you see, I can remove the diagnostic catheter immediately. And after some catecholamine bolus, the situation stabilized. So what can we do? Should we do this with coronary intervention? We have a right coronary artery with a high-grade stenosis. We have the problem if we go in here with any kind of catheter, the patient will get unstable hemodynamically. And we have probably thrombus or atherosclerotic debris in a large amount here. Then we have the circumflex ostium. We cannot even see where to wire the circumflex ostium. It's a long stenosis, proximal circumflex, and we have another stenosis here. So in this case, we decided not to dare this, to treat this interventionally. We did left ventricle, which is surprisingly normal. After the coronary angiography, we got laboratory results. The CK was also normal at that time. And so we decided to transfer this patient to a surgical center. We don't have cardiac surgery in our hospital, so we have to move the patient to another city, even 30 kilometers. So we called them and we organized the transport, and he went to the adjacent hospital in Braunschweig, where he was operated in the afternoon, and he could receive complete arterial revascularization, which is really good, with Lima artery and radial artery. And so he's a young man, and he has complete arterial revascularization, and the operation was uneventful, and he left hospital without major damage at his heart and in good health. So this comes back to the first patient I mentioned to you. You have not only to do good interventions, you also have to have a good organization. In this case, we had to have the good contact to the Braunschweig hospital and to talk to our colleagues to help us with the patient. So they took him and they treated him, and we were very happy that we got a good result for the patient. And the guidelines state that CABG should be considered in patients with ongoing ischemia, large area of jeopardized myocardium, if PCI cannot be performed.